Good afternoon, and welcome to the second installment of IMPACTHER, a special edition in honor of National Minority Health Month. We are so grateful you've joined us for today's powerful webinar, The Importance of Genetics in Breast Cancer. IMPACTHER is a breast health education series presented by SurviveHer and the TSU Breast Cancer Screening and Prevention Center, created to inform, inspire, and empower women through knowledge and advocacy. I'm Lindsay Livingston, a triple negative breast cancer SurviveHer, BRCA1 gene mutation carrier, and founder and executive director of SurviveHer, a nonprofit dedicated to improving breast health outcomes and advancing equity in care. SurviveHer and our partners at the TSU Breast Cancer Center are proud to be members of the Texas Health Equity Alliance for Breast Cancer, otherwise known as THEAL, a collaborative of more than 20 community organizations led by MD Anderson Cancer Center. We are committed to reducing breast cancer disparities across Greater Houston, especially among Black women who continue to face disproportionate outcomes. Our goal as a collective is to cut breast cancer mortality disparities in half within 5 years, which is a super ambitious goal that we are so committed to do. Now, before we get started with our keynote speaker, please make note of the following. We encourage you to use the Q&A box to submit your questions. If you're a community health worker, you'll receive 1 credit hour by completing the sign-in and post-event evaluation. And don't forget to complete the post-webinar survey at the conclusion of the webinar. All Texas registrants will receive a $20 Postmates promo code. Today, you'll hear expert voices in medicine and public health, including our keynote speaker, Dr. Portia Johnson-Williams, and panelists, Dr. Banu Arun and Ashley Dedman, who bring both clinical insight and lived experience to this critical conversation. So let's dive in as we explore how genetics and personalized care can change and save lives. It's my honor to introduce our keynote speaker, Dr. Portia Johnson-Williams. She's a pharmacist specializing in hematology oncology with dual certification in pharmacogenomics. As a strategic advisor for precision medicine and molecular tumor board services, Dr. Johnson-Williams guides treatment decisions and helps shape oncology programs across healthcare systems. Driven by a passion for health equity, Dr. Johnson-Williams leverages genetics and precision oncology to improve cancer outcomes, especially for underserved communities. And I now like to pass the pink microphone to Dr. Johnson-Williams. You now have the floor.
Thank you so much, Lindsay, for having me. Thank you for the SurviveHer team, MD Anderson, and my TSU family. It is such a pleasure and an honor to be here today to talk about something that is of one of the utmost importance in cancer care, which is the importance of genetics. The title of the presentation today will be The Importance of Genetics in Breast Cancer. And so I'd like to level set a bit just to kind of talk about what exactly is precision medicine. So the principles of precision medicine or cancer therapy is shown here in this picture. It takes the idea or the notion that used to be a long time ago that everyone was a one-size-fits-all model and that everyone received the same medication for the same diagnosis, no matter what your DNA was. We know today, with all of the different indications and approvals in target therapy, that that's simply not true. We're not a homogeneous race. And so this really just shows the importance of molecular profiling. And we're able to stratify these patients based off of their prognostic markers, so how well they're determined to do throughout their cancer care continuum. Also markers of predictive drug resistance or sensitivity, and we'll talk about that with BRCA mutations as well as ESR1 mutations, and then markers of predictive adverse events. By being able to stratify these patients into various categories, we're able to get them the right drug for the right patient at the right time. Next slide, please. So I want to talk about the definition of biomarkers. When we talk about precision medicine, we hear different terminology. You may hear next generation sequencing, testing, biomarker testing, genetic testing, and really we just want to kind of level set what that all means. And so the terminology of tumor markers and molecular markers are a marriage of the two, which culminates under the terminology of biomarkers. So let's talk about the difference between tumor markers and molecular markers. As you go through your cancer care continuum, you might see different lab results known as tumor markers. So you'll see a CA-125 or 15-3, things of that sort. And this is predictive of how your body is responding to the cancer therapy and how well you are doing or not doing on your treatment that is aligned with your diagnosis. And then we go to molecular markers, which is more aligned with our targeted therapy options. And so these specific markers actually indicate if the tumor will respond to treatment, as we talked about before in that previous picture. And you'll see the ones that are most known for breast cancer as well. Knowing that also we have some tumor agnostic markers, meaning that it's not necessarily only indicated for breast cancer, but beyond other different types of tumor types as well. Looking at the difference between genetics and genomics, again, these are some terminology that you may hear interchangeably, but I want to level set as far as what the difference is. So genetics is based off of the study of individual genes or inheritance. This is what has come from mom and dad. This is what you will always have, no matter if you have cancer or not have cancer. And so they call this germline genetic testing. And it really, again, looks at the patient's DNA and their protein level and also the RNA level to, again, determine what their treatment options may look like. Genomics is more so the study of multiple gene functions and how they interact with each other and the environment known as epigenetics. We're able to evaluate and profile the tumor itself, and that's mostly known as somatic testing to, again, determine how that is maybe different or the same as your germline or inherited profile and how that may affect your response to therapy for cancer. How do we apply these two testing models to cancer care? Germline genetic testing, again, this is something that you receive from mom and dad, whether you have cancer or don't have cancer. This is able to identify your cancer predisposition or how likely or unlikely you are to have breast cancer or any other type of cancer. It also encourages proactive and prophylactic measures. So whether that be surgical resection, such as mastectomy or lumpectomy, but then also the frequency of screening, such as MRIs, and also looking at mammogram frequency as well. And then we have implications of drug therapy. So for instance, if you're a brachytherapy, you may be eligible to receive something known as a PARP inhibitor, such as olaparib. Or if you're hormone sensitive, you may be eligible for endocrine therapies, which we'll get into in a little bit as well. Now, looking at genomic tumor profiling, this contributes to your comprehensive informed treatment planning. I say it's better to have and not need than need and not have. And knowing that profiling of your tumor and your germline is the ultimate playbook for targeted therapy and for your treatment planning for cancer care. We're also able to identify potential therapeutic targets, as well as leading to discussions or discovery of any plausible resistant mechanisms, again, like that ESR1 mutation that we'll talk about in a little bit. Now, I love to show this diagram because we know that if you have a mutation, it doesn't necessarily mean that you have cancer. But if you have a cancer, there is a 10% risk that it is linked to something hereditary. And so we'll kind of talk about those three different buckets that this kind of falls into. So hereditary cancer, again, this is from mom and dad. This is something that is heavily linked to some type of genetic variation. Familial cancer is something that my family has personally experienced, meaning that we have prostate cancer, breast cancer, lymphoma in our family, but we have not been able to identify a known mutation. And so this is, has some psychological implications because there's nothing that you really know that you can do about it from a treatment standpoint, but it does affect you from a screening and preventative measures as far as MRI frequencies and mammograms. Sporadic cancer is something that is most commonly seen here in the blue, 70 to 80%. There's no known cause. It just happened, unfortunately, and it could be due to environmental factors such as smoking or asbestos exposure, also lifestyle. And we know that there are several social determinants of health, whether it be redlining of the institutional care that you're able to receive and the quality of cancer care, but even lifestyle choices such as obesity and food choices as well. So there are several options that you can do germline testing. We know that tissue is the gold standard, and that is particularly if you have a tumor that they can resect or surgically remove bits of it to send off for molecular profiling. But for those that are just receiving germline testing, or if you have cancer and the tissue is not available, we have what they call liquid biopsies. And so you'll see here 3 different options in which you can do this, and they can actually send someone to your house to do a phlebotomy, like a blood draw, or in my case, I did a saliva test where they send you the entire kit and you're able to collect your saliva in this test tube and send it off for testing, and they send you back the results. So it's very, very accessible. You can do it whether a cheek swab with a Q-tip that's provided, a saliva test through that test tube, or a blood draw, as you see here, which will be in a doctor's office, or a phlebotomist maybe come to your home. So let's go into what the testing criteria may be for someone that maybe has a high risk or propensity for developing cancer. So when to think about genetic testing, we're looking at your family history. Is there a personal history of breast cancer? Or do you have a known family history of cancer risk mutations such as BRCA1 or BRCA2? This is why it's so important to have those vital conversations with your family. And I know in certain communities, it's better left unsaid, as they say. People are not as vocal or as transparent about the diseases or the cancers or ailments that they may be experiencing. But as you see here, it's so, so important to be informed all around. Also, clinical implications. So pathogenic, meaning a bad genetic variant or likely pathogenic, if that's identified on your tumor genomic testing, it also has clinical implications as well as if it's identified in the germline, again, something that came from mom and dad. We talked about before how this influences treatment decision making. So again, whether there are target therapies, they're able to actually target that mutation on your cancer cell, or if it helps you with surgical options that may be needed, such as mastectomies or lumpectomies. What should you discuss with your healthcare provider? Again, screening is key. For those with these certain gene mutations, we want to consider starting mammograms or MRIs earlier than the FDA recommendation. Looking at tailored treatments, the genetic test can guide these personal treatment choices. Again, it is the ultimate playbook for how to effectively manage your cancer care. And then family health. This helps identify if family members may be at risk, and it helps us to seek post-test genetic counseling to see how we should move forward and who else in our family should be tested for these mutations. And then as far as a comprehensive care model, we know that the gene panel testing helps determine the best treatments or even clinical trials that have eligibility criteria based off of your biomarkers, and then post-treatment testing as well. We know that cancer is very smart. It tends to outsmart our targeted therapy options. If for any chance you are on a target therapy or a chemotherapy or an agent of choice and it stops working, we do recommend that you get retested from a germline and I'm sorry, not a germline because that doesn't change, but from a genomic standpoint off of your tumor, because we're able to see what the genomic landscape may look like from then on. So then we also have testing criteria for high penetrant brain cancer susceptibility genes. That would be like your BRCA1 or BRCA2 mutations, those that are known to inhibit breast cancer. Also, knowing personal history of breast cancer with special features is so important. So patient selection, those patients that are 50 years old or younger should receive this type of testing if you are known to have these high penetrance susceptibility genes. And then also for those that are of any age, we're looking at, again, treatment indications, pathology, male breast cancer, and then those that have an ancestral history of Ashkenazi Jewish or even high-risk family history, again, those that patients that have breast cancer or prostate cancer within their family or a known BRCA1 or 2 mutation. And those that have high-risk family history, again, is listed here. Male breast cancer, ovarian cancer, pancreatic, and prostate are very well known as a high-risk family history. Here I've listed a family pedigree, and this is something that you could draw on your own with your family members, or they may draw this in office, and there's also different electronic ways to draw this as well. Knowing that the mother's side or maternal side is on the left side, and the paternal side is on the right side. Here you'll see here in green are those patients, are those family members that have been affected with cancer in some sense of the form. And also the patients that have the slash through them have actually passed from cancer. A proband is a patient that is actually drawing this on behalf of themselves, and that's where it kind of determines, and then you can see their family lineage from there. This is so important to take into your consultations and your clinic visits so that you have a visual diagram of what your risk factors may be. Next slide. Hormone receptor testing is something that means that your cancer, especially breast cancers, are hormone sensitive. So your estrogen receptor or your progesterone receptors, and this is performed via a lab test known as immunohistochemistry. And this should be performed on any new primary or newly metastatic breast cancer. With using ER testing, we're able to determine which patients are candidates for endocrine therapies. And I want to point out that it's a spectrum now. It's not just ER positive or ER negative. Now there's an in-between of ER low. So it's so important, again, to be able to work with your pathologist, work with your medical oncologist to determine where exactly you lie. And if you were previously determined as ER negative, you may now be determined as ER low and have eligibility to these endocrine therapies, which we did not have before in years to come. ERBB2 or HER2 is also a marker that I want you all to be aware of. It's based off of different expression levels or amplification. So to your left, you have a normal cell, which would be determined as HER2 negative. And then to your right, you have a positive cell of HER2 positive based off of the number of HER2 receptors that are on that cell. Again, like how we talked about with the hormone receptors, we are now on a spectrum. It used to be HER2 negative or HER2 positive, and now they have two new gray areas, so HER2 low or HER2 ultra low. And as you can see on this diagram from the right, it is all based off of subjectivity from the pathologist that is reading this. So again, if you have had previous testing or they've told you that you're HER2 negative or even triple negative breast cancer, it's important to have this reprofiled to see if you are HER2 ultra low, HER2 low, or even now HER2 positive, because cancers, again, are heterogeneous, meaning that where you may test from one area may be negative, but if you test from another area of the breast, it may now be positive or ultra low. This opens you up to a new spectrum of treatment options. This is something that's not often talked about, but it is actually a therapy that is known in breast cancer, being capecitabine or Xeloda. So beyond your germline testing and genomic testing, we have to think from a genetic level as far as your metabolism. So this particular medication known as Xeloda or capecitabine, which is an oral medication for breast cancer, it has in the package insert in the leaflet that comes from the FDA, if you are deficient or low in the enzyme that metabolizes this drug, you could be opening yourself up to a world of toxicity, such as mucositis or inflammation of the mucosal lining, thrombocytopenia, low platelets, meaning that you're easily able to bleed out. And then also you're looking at neutropenia or the decrease in your white blood cells and leading to infections or even fatality. So again, this is something that I really want to put on everyone's radar because I don't think it's spoken about and it's not a general practice here in the US to test for this. But again, if you are deficient or if you have low levels of the enzyme that metabolizes this drug, it can be very, very toxic for these patients. Now let's talk about some potential barriers that may prohibit someone from getting genetic or genomic testing. We know that testing prices and reimbursement vary. Your insurance carriers are not all the same. It is so vital for you all to speak up about any type of barriers that you may be experiencing from a financial standpoint, because there are several patient assistance programs that are available. So again, closed mouths don't get fed, and we have the capabilities to be able to cover these copays and to cover whatever the insurance does not cover at all. Turnaround times can also be an issue. Looking at, it can take up from 2 weeks to sometimes a full month, depending on the lab vendor as well. Requirements for tissue to perform testing. Again, we talked about you may be able to even do liquid biopsy. So that's the cheek swab or the saliva testing, or even looking at the blood draw. And then we're going to talk about some racial and socioeconomic disparities. And then let's not forget, even in the midst of COVID and beyond, we've identified some healthcare workforce shortages, especially with genetic counselors. We need genetic counselors to be able to read out the results of the genetic and germline testing to actually help out with treatment planning. So these are some barriers that I have personally identified. Social considerations. I often get the question about different testing such as 23andMe, or you may hear Ancestry.com. Those are what we call recreational genetic testing, and they don't have the clinical validity to help with treatment planning, as we talked about before. So just want to put that on your radar as well. Social determinants of health. We talked about all treatment care and cancer care is not created equally based off of if you're in a rural area or you're near an academic center. And then also knowing that we are an admixture of race and we have several subpopulations with our ancestry. Knowing that we're not all a homogeneous race, it really determines how we're able to clinically identify who belongs where in the treatment spectrum when we have the genetic dispositions and the genetic testing results and where that reads out as far as a genomic database. The Genetic Information Non-Discrimination Act, known as GINA, is something I want to also put on your radar. We have several questions about what happens to my DNA What is this? How does this affect my insurance? And so the Genetic Information Non-Discrimination Act, known as GINA, it prohibits medical insurance or employers from discriminating against individuals based off of your genetic information. There are three caveats here that the GINA Act does not cover. So it does not protect against those with life insurance or long-term disability. It does not shield those that are part of a government agency, such as IHS, the VA, federal employees or military plans, and those that are employed by private employers, usually those that have less than 15 employees. There has been a call to action for all pharmaceutical industry companies to have a plan for increasing the diversity in clinical trials. Given the state of our political climate, please understand that this may be fluid or evolving call to action. But we know that the number one drug rule is to never take someone else's medication. And by taking a medication that did not have your particular ancestry or your particular representation in those clinical trials, we're doing just that. So it is important to have this genetic testing to actually influence clinical trials moving forward and influence the founding of medications that are particularly meant for you. We must meet patients where they're at. So community organizations such as Survive Her, recruitment strategies, HBCU, I'm a proud Howard grad, and we have our TSU family here. It's so important to meet patients where they're at. Patient advisory focus boards and focus groups. I often say nothing about us without us. We must be part of the conversation. We must be at the table in order to move this forward and have a true representation of what our community looks like and what exactly we need. Also knowing these social determinants of health, we need to make sure that there are meal and transportation vouchers to get to these clinics, to get to the clinical trials, to get to the testing facilities, monetary incentives, having a hub and spoke clinical trial model beyond the academic care center, going out into the community to offer these clinical trials, and then diversify the clinical workforce. We know that patients seek care from those that look like them or that can advocate on their behalf. Last but not least, how do we empower you? How can genetic testing help with breast cancer? We have to personalize our treatment. Again, we're not a one size fits all model anymore. We have targeted therapies that are able to help you personalize your treatment based off of your DNA within your own self. Early detection is so key. Knowing that if you have a predisposition to a certain cancer, we're able to increase the screening and figure out what our vigilance plan looks like going forward. Family health, influencing what your relatives and your generations to come, how they're able to successfully thrive in this environment. And why should you talk to your provider? You want to get the right information. Do not rely on Dr. Google. Get the right information from the horse's mouth. Discuss the benefits and the risk and help make informed decisions together. And then how do you start this conversation? Ask questions, stay curious, stay vigilant, share your concerns, whether it be variants of unknown significance where we don't necessarily have the answer to, or whether it be financial assistance, transportation, meal vouchers. You have to open your mouth and say what you need in order for us to help you and stay informed. And last but not least, be proactive about your health. Take charge. You are an advocate and just as much part of this healthcare team as any other physician, any other pharmacist, any other nurse, and support your family from here on out. Thank you so much.
Let's give a virtual round of applause to Dr. Johnson Williams. Thank you so much for that extremely comprehensive, informative presentation, and for clearly breaking down the role of genetics in breast cancer, specifically stressing the importance, Dr. Johnson Williams, of why we should know our family history and actionable steps that would empower us as a community to know our status. Your insights truly will help women and men to better understand their risk, explore personalized options, and confidently advocate for their best breast health and outcomes. Keyword advocate. So thank you again for that information. Dr. Johnson Williams will now be joined by our panelist. Dr. Banu Arun is a professor of breast medical oncology and co-medical director of the Clinical Cancer Genetics Program at MD Anderson Cancer Center. Her research focuses on breast cancer genetics, chemo prevention, and identifying hereditary cancer risk in underserved communities, particularly among women with BRCA mutations. She has led multiple clinical trials, serves on national oncology committees, and was recognized by Forbes as one of the top 30 breast medical oncologists in the U.S. Welcome, Dr. Arun. Ashley Dedman has over a decade of leadership in breast cancer advocacy, public health, and genetics. As a BRCA2 previvor and former teen caregiver, Ashley has held key roles at the American Cancer Society, Susan G. Komen, and numerous national advisory boards focused on equity and cancer prevention. Ashley is a certified health education specialist, author, and current doctoral student researching how chronic stress and social factors impact breast cancer risk in Black women. Welcome, soon to be Dr. Ashley Dedman. So let's get started. I'll start with you, Ashley. As a public health practitioner and BRCA2 mutation carrier, your voice is incredibly powerful in this space. We'd like to know about your personal journey with genetic testing and how it shaped your approach to breast health.
Thank you, Lindsay. Thank you first for the opportunity for Survive Her, for having this educational platform, and for Dr. Johnson Williams on your presentation. When we talk about, family health history, I really want to underscore a lot of the things that Dr. Johnson mentioned. And really, my journey really began with having a doctor who empowered me. For me, it's really important that certain doctors on my clinical team look like me, and that is my OBGYN as well as my PCP. I do have a very diverse medical team because for me, it's truly two simple criteria: that you are the best of the best and that you see me as a Black woman. And so I don't care what you look like, as long as those two things meet my expectations, that's what's important for me. So it really began with having an OBGYN who really pushed the importance of me knowing my family health history. So screening for family health history annually as I went in. But she also reminded me that if my family history changes or I find out new information, to not wait for my annual visit, but to call her immediately. And so I have a family health history on my maternal side, my mother's side, and I do have a pedigree that Dr. Johnson spoke about. On my maternal side, my mother had metastatic breast cancer, which is stage 4. She has passed away from metastatic breast cancer. My great-grandmother also had breast cancer, and then my great-great-grandmother had breast cancer. On my father's side, my paternal side, my father is a prostate cancer survivor, and I also have a breast cancer on my paternal side. So knowing all of this family history, and this is family history to date, but I didn't know all of this when I was 21, which is when I lost my mother to metastatic breast cancer or the complications thereof. And shortly after my father was diagnosed with prostate cancer, that's really what swung me into action, to going back to my doctor to update her on new family history and learning about new family history from past family members. That's when we really began to talk about genetic counseling and genetic testing. And I was very fortunate to go through pre-counseling and post-counseling. Pre-counseling really helped me to understand what genetic testing was, and post-counseling really helped me to understand the next steps as it related to my medical management. I will say that my mother was not talked to about her family health history. She was not offered genetic testing, and we know that that is actually a disparity within the Black and Brown community. It's the communication of genetic counseling and genetic testing from provider to patient. And so knowing all of this, it really swung me into the next phase, which Lindsay, you brought about, was how do I approach my breast health? And that was through medical management. And it's not just my breast health, but it's all the aspects of my health that are related to my particular mutation. So I do carry the BRCA2 mutation, which makes me a high risk for breast cancer, ovarian cancer, and if I was a man, prostate cancer, and also an elevated risk for pancreatic, elevated risk for pancreatic and melanoma. And so knowing all of this, I began my medical management at the age of 21, where I began early initiation to screening, where I had breast MRIs, breast ultrasounds, and breast and mammograms at a very early age, very frequently, every 6 months, so that I could aggressively monitor my breast and ovarian health. I also had and still have CA-125 blood work, which helps me to monitor my ovarian health. And I plan to remove my tubes this year so that I can drastically reduce my risk of ovarian cancer. And then as I wrap up, I will say that I did receive genetic testing in 2021. And since then, there's been advancements. And so I just received updated testing in December where I found out that I carry a VUS. And so sharing this information with my clinical team, I am now also receiving and getting an endoscopy and a colonoscopy as it relates to my BRCA2 mutation as well as my VUS. And that's the colonoscopy is just a decision that my GI and I made just to be very aggressive and preventative. And then also, you know, when we talk about family history, this is something that continues because my husband and I have two girls. My husband has a family history of cancer, and he actually underwent genetic testing last fall, and I will share that he does have a mutation. Which mutation I will not share, that is for him to share, but as a family, that is really helping us to prepare the next steps for our two daughters, and how we can begin to prepare them and educate them on what their medical management will look like going forward when guidelines permit them to begin medical management. And I think it's important we have these discussions, but I think it's also important too we leave this information as a legacy for our family. As I shared, I have a pedigree, as well as I have our DNA genetic testing results. We have them in our living will, so that if something were to happen to my husband and I today, that our girls have this information so that they can navigate their health in the healthcare system.
Thank you so much, Ashley, for sharing your personal journey with genetic testing, how it shaped your health, your medical management, and how you are caring for and thinking ahead to how generational health, right, with your daughters. You touched on so many important points that I just want to punctuate before I pass the pink microphone to Dr. Arun. You started your medical management at the age of 21 after learning about such a significant and storied history in your family of BRCA1/2 mutations, your maternal and paternal sides. You took action. You started your management early and then made a decision to have the prophylactic surgeries to drastically reduce your risk. I can't stress the importance to our audience, the importance of knowing your status, your genetic status. When I was diagnosed at the age of 37, I did not know of a known family history of the BRCA1 gene mutation. I was the 14th female on my paternal side to have been diagnosed, but we were not talking about it in our family. We must, as Dr. Johnson Williams stressed in her presentation, as Ashley just stressed, we must have these conversations in our family to empower, to inform, and inspire each other to get genetically tested. Dr. Arun, from a clinical perspective, Ashley's story really illustrated the importance of early awareness and access. But could you speak to the significance of genetic counseling and testing in the early detection and prevention of breast cancer?
Yeah, thank you. First of all, thank you so much for inviting me to this wonderful and very important webinar, very timely. And I appreciate Dr. Johnson Williams' lecture and Ashley's testimonials and personal insight into this. So I will kind of try to contribute from a provider's perspective, but also as a person who has been now doing this for 25 years. And as you can imagine, have patients I'm seeing for 25 years. Thankfully, many didn't develop cancer because they did all of the risk reductive interventions or surgical interventions as well. So we have over time become friends, and they sometimes know the literature better than I do because they are following up. So I'm on the provider side, but have long years of relations with my patients, high risk patients especially. So the importance of knowing your genetic information and mutation for early detection and risk reduction of, and I will focus on breast cancer, um, uh, is really very important because first of all, when we know that there's a germline mutation, we can quantify the risk better. So as you all know, there are other risk factors, right? I mean, like early menarche, late menopause, not breastfeeding, childbirth after age 30, smoking, alcohol, and others. But it's hard to quantify that risk. And when you cannot give a number to something, it's hard to do interventions because we are used to see, okay, this is my risk. It's 30%. And if I do this, I reduce it by whatever percent. With when we identify germline mutations, we have the luxury, not 100%, but we can give numbers. So with BRCA mutations, in TP53 mutations, for example, we know that breast cancer risk is more than 50%. We know the numbers for ovarian cancer, but also with the newer mutations such as CHEK2, PALB2, other hereditary germline mutations that increase the risk of breast cancer and other cancers. Though we have a range, we still have numbers. So again, the benefit of doing the genetic testing and knowing whether it's positive, whether it's a pathogenic mutation, can help us with kind of putting it into perspective, in terms of numbers, because that will then help us doing the risk reductive discussions, whether it's healthy lifestyle, whether it's surgical interventions. And again, surgical intervention does not mean that everybody who has a germline mutation has to do it. It depends on the gene. It depends on other comorbidities. It depends on the age and also obviously personal decisions. And also chemoprevention, reducing the risk of breast cancer with an agent, for example. And here is the pre-genetic testing, genetic counseling important because we have sometimes patients who have undergone genetic testing and then the results are given to them and then they come to us and have no idea what was really the indication. What do the results mean? So they are not prepared, especially if we get the VUS result. And, Ashley just mentioned the VUS is a variant of uncertain significance. So we have a mutation, but we don't know what it really means clinically. We cannot put a quantification on the risk. We don't even know if it increases risk. And therefore, we cannot recommend any risk reductive interventions. So all of these caveats or details ideally should be discussed before we do the testing. That's where pre-testing genetic counseling is very important because I tell my patients, like, I would recommend you are eligible, but do you want to proceed? We can have positive results, then we will be discussing this. So it's not a shock when I say, maybe it's better if you remove your ovaries, your breasts. I also say we might get a VUS result. What that means is I will not be able to tell you what that means, and you will not be able to make a decision. Are you ready to receive this? And I can tell you that many times when I discuss it, it's not that patients decide not to do it, but it's important to know it because if you get the results and then come back with the results with the hopes that it will mean something and I will make concrete recommendations. And if it's a VUS, I cannot. It's a huge disappointment. It's anger. And then it's also, why did I do the testing at all then? So it's better to discuss all of this before the testing. Give ample time to do a discussion, discuss the scenarios, then do the testing, then get the results and continue to the discussion. And getting the one thing is also I tell my patients is when we review the results, it doesn't mean that you have to make the decisions that second because we are discussing the options right now. It's an ongoing conversation. It's a process. And one thing, there is no one simple answer that would fit all. So we of course, have to understand that as well. And that's where the post-genetic testing counseling is also important. I don't know, Lindsay, if I answered your question or if I went off because I can go on and on for the whole thing, but I will just stop here and see whether, there are any further questions related to this or others?
No, you answered it thoroughly. Thank you so much, Dr. Roon. I think there's just so many facets to genetic counseling and genetic testing and decision making. But you made some important points in that you want to sit down with that genetic counselor, look at the options, and then make your informed decisions about your preventative measures. So thank you so much. We could spend hours talking about this because it's so important. But for the sake of time, I want to pass the pink microphone back to you, Dr. Johnson Williams, so we could talk about more so the treatment and the pharmacogenomics around testing. You specialize in the application of personalized medicine. So how does genetic testing influence treatment planning and medication choices for breast cancer patients?
Absolutely. So pharmacogenomics, again, is the ultimate playbook for your cancer care continuum, whether that be risk reduction, interventions, or even target therapy options that are present today. But something that I do want to kind of piggyback off of Ashley and Dr. Arun is that everyone is not given this option. And that's where implicit bias comes in, or unconscious bias. For instance, my father is a two-time prostate cancer survivor, and given his extensive lineage and family history of various cancers, we went to a top-notch academic institution, and my father is, financially stable, very intelligent, a professional, and never once was offered the opportunity to have genetic testing. It wasn't part of the conversation or anything of that sort. So it wasn't until he came back home, and I now have two little ones of my own, that it was important to know what my risk factor was and how I could make sure that he was here to see his grandkids and to live a full life. And so we were actually able to advocate for ourselves to both have genetic testing done at that time. So I don't want you all to take for granted that this is an option that's often discussed. Sometimes you have to bring it up and advocate for yourself. And if they say no, seek a second opinion and go forward from that. Because again, if you have the information, you know what you're eligible for, whether it's a target therapy or an agent that is available on the market now, but then often a clinical trial, which we often say is, tomorrow's medication that you receive today through a clinical trial via the eligibility criteria from the biomarker results. With the variants of unknown significance, with me having a familial family history of cancer, again, not having a pinpoint of a genetic mutation, I have a VUS. And we're hoping that the more people that are tested, especially minority communities, we can add to that genomic database to influence reclassification of a VUS to now pathogenic or something that we know how to act upon, or even influence new drug discovery based off of those biomarkers. But we have to have more people testing, whether you have cancer or not, in order to continue to build up that database so that, again, we're not taking someone else's medication that's not meant for us.
Thank you, Dr. Johnson Williams. You raised a point that I want to address to both you and Ashley. Ashley, given that you work in the public health sector, what challenges do you see in the Black and Brown communities when it comes to accessing and trusting genetic testing? You just mentioned, signing up for a clinical trial, et cetera, genetic test. But how can public health messaging be improved to really address the stigma, the fear, the mistrust around hereditary cancer risk in the Black and Brown communities? And I'll let you, Ashley, and Dr. Johnson Williams kind of tag team this question.
Absolutely. I think first off, it's stating that cancer is a public health issue. Breast cancer is a public health issue. I think when we look at in the Black and Brown communities, I know Dr. Johnson Williams shared a lot of this information earlier. I think it's the historical trauma and medical mistrust. I think we have to acknowledge that. I also believe that a lot of that historical medical mistrust is being now, it's still happening today. I want to acknowledge that, but I also believe it's being weaponized as a reason for not all, but certain clinicians not to test, right? Because I've heard people say, well, Black people don't trust this anyway, or they won't be able to understand this information. And, it's really disheartening to hear. So we have to acknowledge the medical mistrust historically, but we can't weaponize it as an excuse to not test or not to communicate genetic counseling and genetic testing to Black and Brown communities. I really believe that we love our lives. We want our lives to be saved. We want great health outcomes, but we do not know what we are not presented with. And it's opportunities like this where we're given knowledge. And so I would say those are the two things. And I'll finally say too, I think, again, as I shared earlier, for me, it's about having a medical team who sees me as a Black woman. And regardless of what your background is as a doctor, as long as you can see me as a Black woman and you're the best, that's what's important to me. But I also think too, when you look at the profession of genetic counseling, when you look at the National Society of Genetic Counselors in April of 2021, they shared that there's about 5,000 plus genetic counselors in the profession, and about 2% of those are Black genetic counselors. So genetic counseling and representation is important, but I also want to acknowledge that genetic counseling is a growing profession. So I think it's important to also increase that pipeline at the HBCU level, the university level, where we're pouring more and pushing more Black and Brown students into this great field.
Absolutely. And I think too, as we have our social media and we have such heightened visibility of these public platforms, not only should we ourselves be public figures, but then also tap into those that are maybe celebrities that also have an influence. I was on Instagram the other day and saw that Beyonce's mom, Tina Knowles, has recently been diagnosed with breast cancer. And you could see the amount of interactions and comments that were on her thread. And I think that that is so important for the transparency of, yes, you're a celebrity, but not being so closed off that you cannot impact in a positive manner your community that looks up to you. So again, it's just important to have those conversations. We talked about in my presentation, the Black and Brown community usually keeps things lock and key, and we should not have that mentality of, not airing, quote unquote, your dirty laundry. We have to talk about this. And by being able to talk about this, we equip ourselves and empower ourselves to continue to advocate for ourselves even when others don't. And we may not trust other people, but we trust ourselves. And by empowering and having the knowledge ourselves, we know how to move forward and what works best for our family and how to influence, again, generations to come.
If I may, I would like to add as well a little bit. Lindsay, I want to share actually something that is very uplifting and I think telling us that we are heading towards the right direction. Maybe some of you know, we've had a program where we partnered with Susan Komen's Worship in Pink initiative, where we would go to churches and do a brief 10-minute educational seminar, very informal, myself, my coordinator, my genetic counselor, with some slides for 10 minutes, and then invite the audience to, if anybody is interested, to be assessed whether they are eligible for genetic testing. And we would actually bring spit kits and do the testing there if they're eligible. And we also had our community healthcare workers that kind of, bridged the communication, and the trust that we learned is very, very important. But I can tell you more than 90% of the audience would come up to us to participate. Not everybody was eligible for testing, which is normal, right? I mean, that's expected, but 90% would come and sign up, sign the consent to do that quick screening to see whether they're eligible or not. And if eligible, more than half of them actually stayed to spit in the little spit kits, which we then would take back and do the testing, and we would do follow up. So I think what we learned is that, community engagement, building trust, and education and persistence. We didn't give up for a whole year. We went to gatherings as small as 10 people. We went to gatherings as large as 100 or more aware people. So I think working together as a team and persistence and education and trust building is important. That's what we learned.
Thank you all for responding to that question specific to how we can best empower and educate Black and Brown communities to get genetic testing. And Dr. Arun, we all giggled when you said and referred to just the quick spit test. So it's simple as that, right? It's not, so that should immediately strip away some of the
Yeah,
fear around the testing process.
exactly. And that's really a technical term. It's simple because obviously the whole essence of it is not simple. There's so much, but it's compared to a blood draw, much easier and faster and convenient. Yeah.
Thank you for sharing that, Dr. Arun. Just in closing, I want to pose a question to each of you. And in 30 seconds or less, what's a piece of advice you would give to our audience today on how they can use genetic knowledge to take charge of their breast health through risk reduction, early detection, or simply advocating for personal care? I'll start with you, Ashley. 30 seconds or less.
Yeah, I'll go. I think it's telling your story. And I will say storytelling is powerful. It humanizes the science. I've had the opportunity to work with Dr. Roon. She's a compassionate doctor and provider. She's so passionate about her patients. And I think when you couple that with an advocate who is telling their story and eager to learn more and take care of their health, I think it's a great match.
Thank you, Ashley. Dr. Johnson-Williams.
Absolutely. I'll end with a quote that my father always says, if you stay ready, you don't have to get ready, right? And so with that, if we know better, we can do better. So just knowing the knowledge, being fully equipped with what your risk factors may be, and you'll be able to successfully navigate whatever your cancer journey may be.
Thank you, Dr. Johnson-Williams. And Dr. Arun.
Yeah, so I want to echo Ashley and Dr. Johnson-Williams as well. I think knowledge is power. What I would say is, be equipped with all of the knowledge, be equipped with your options, but also know yourself because, again, we have cases where the same mutation, two people can make complete different decisions because it's an internal process. So know yourself also, your expectations, what you're comfortable with.
Thank you, Dr. Arun. So know yourself, find advocates within the healthcare system, as Ashley mentioned, and Dr. Johnson-Williams said, knowledge is power. Thank you all so much for contributing to this very informative, engaging discussion around the importance of genetics as it relates to breast cancer. I do want to transition to a brief Q&A segment. We have a few questions from our audience, one of which is, how does genetic research contribute to the development of new drugs and vaccines? Dr. Arun or Dr. Johnson-Williams, I will direct that to you.
I mean, I can get started. For example, the most classical example is, germline BRCA mutations, and in some cases also somatic BRCA mutations. The mutations in the tumor has led. The investigation and research has led to targeted therapies in this population for the first ever time with PARP inhibitors, ovarian cancer, breast cancer, and now also pancreas and prostate cancer. That's one, very, very important and classical example.
Absolutely. And as far as vaccines, I mean, we know with the COVID vaccines, a lot of them are based off of mRNA, which is basically, it doesn't have to be informed by a tumor type or individualized, right? And so as we're talking about how we can kind of parallel to discoveries that have already been made, we're also looking at how we can use maybe mRNA that does not have to be tumor informed or doesn't have to be personalized or for various injections and things of that sort. Again, it all just depends on what our genomic database looks like. We have to have the material in order to move forward with that research. And the only way to do that is to be active participant in those research conversations.
Phenomenal. This was just, we could talk about this for hours. Thank you so much, Dr. Johnson-Williams, for your presentation. Dr. Arun and Ashley, we are so grateful for your voices today, for your professional insights, for your perspectives, both personal and professional, the advice that you shared with our audience. Thank you so much for informing, inspiring, and empowering women to get a genetic test to know their status so that they can reduce their risk for breast cancer and or know whether which they are predisposed to a breast cancer and elevated breast cancer risk, that they can also integrate this information into their day-to-day lives and share with their family members. So thank you to each of you for your time today. I'd now like to transition to our partner spotlight and introduce Dr. Veronica Ajiwole. She is the director of the TSU Breast Cancer Screening and Prevention Center. Dr. Ajiwole.
Hello, hello. Wow, what an amazing session. I am sitting here just, soaking up in all the great information that has been presented today. Thank you so much, Dr. Johnson Williams, Dr. Arun, Ashley, for sharing professionally, personally, of your insights. And I'm certain that the community has been empowered, to take the right steps regarding a better health outcome when it comes to breast cancer and other health-related outcomes in our lives. Well, Lindsay, it's such a pleasure to partner with you, Survivor Again on this initiative. My name is Veronica Ajiwole, clinical pharmacist by training, and I have the privilege to be the principal investigator and the program director for TSU Breast Cancer Screening and Prevention Center. Just a little bit about us. We offer no-cost screening, diagnostic mammogram services, focusing specifically on women who are disproportionately impacted with breast cancer, mostly uninsured, underinsured women living in Aris, Grimes, Matagorda, Walker, and Wharton County. We just don't offer screening. We also ensure that we provide patient navigation, barrier reduction services to ensure that women are enabled to screen and receive whatever services and care that they need. Scan the QR code. The link is already posted in the chat box so that way you can connect with us, request education services, mammogram services, or navigation services as needed. Next slide, please. And I'm really also very excited to share that as part of our educational programming, we host our biggest annual breast cancer awareness event. We have titled it, "We Roar Against Breast Cancer." Texas Southern University's mascot is a tiger. So when a tiger sees what we don't like, we roar. So breast cancer is definitely one of those things that we want to eliminate from our community. So we roar against breast cancer. This is the actually the 5th annual We Roar Against Breast Cancer is going to happen on October 31st. It's a Friday here at Texas Southern University campus. I invite you all to be a part of this amazing event. Feel free to join us in person. If you can't come in person, we definitely welcome you to join us online, either on Zoom, Facebook, YouTube, wherever you are. We definitely want you to engage with us with this amazing information. And, again, highlighting the great work that we do, we are funded by CPRIT. CPRIT is a cancer prevention research institute of Texas. And over the past 3-4 years now, we've had the opportunity to provide mammogram at no cost to over 1,400 women, education to over 4,000 women, patient navigation services to over 4,500 women. And obviously, I don't do this alone. I have the privilege to work with amazing groups of individuals. Dr. Nkechi Ogbo on the call with us today, Omonike Shomanda on the call with us, our navigator Dolores Ramirez, and several other team members who definitely support the implementation of the work that we do at Texas Southern University. Next slide, please. I'm also very excited. Those that have been following us for some time now would know that we've recently shared that we are launching the mobile unit for Texas Southern University. And I'm very, very excited to share that our mobile unit has been delivered. I felt like literally I was giving birth to a baby when we went to receive this mobile unit. So our mobile unit has arrived. It's currently here in the grounds of Houston. And, we are just waiting to figure out a few logistics so that way this mobile unit will be able to offer services to the community that needs it the most. If you would like to partner with us on this mobile unit, again, feel free to scan the QR code or click on the link in the chat, and you can connect with us on avenues for us to be able to partner and collaborate regarding the mobile unit. Next slide, please. The last information I want to share here briefly, throughout this conversation, Dr. Arun, Dr. Johnson Williams, they mentioned a lot of great information about, access to clinical research regarding, ensuring that the genomic pool is as representative as each and every one of us on this call today and as representative of our community. So Texas Southern University has listened to the call from the community, and we're also very excited that we have recently launched our clinical research registry. TSU is now positioned to become a clinical research site. So what does that mean? Participating and joining the clinical research registry is a step in the right direction that opens up an opportunity for community members like each and every one of you to be part of clinical and medical advancement. Feel free to scan the QR code or click on the link so that way you can get more information and be able to receive information on how to participate in this registry and any other future innovations that we have at TSU. Thank you everyone again for joining us for today's program. We are really excited, and I will turn it back to Lindsay and Christina for more information.
Thank you, Dr. Ajawale. Survivor just really is thrilled to partner, as always, with the TSU Breast Cancer Center. So thank you for what you do for our community. I'd now like to turn it over to Christina Mackey. She is the T-Hill Program Manager for Survivor and our Director of Partnerships and Initiatives, to share a very brief overview about what we do over in Survivor Land. Christina?
Thank you, Lindsay. Wow, what a wealth of information on this call today. So much life-saving gems and resources. And I am personally just so grateful to Dr. Arun, Dr. Portia Johnson-Williams, and Ashley for saying yes to Survivor and being on this call with us. Just thank you everyone who's on the call and watching today for being here. My name again is Christina Mackey, and I serve as the Director of Partnerships and Initiatives for Survivor, as well as the Program Manager for our IMPACTHER initiative through T-Hill and our partners with TSU. As a 2-year stage 3B triple negative breast cancer survivor, I am deeply, deeply connected to our mission to inform, inspire, and empower women worldwide. We are committed to providing these critical resources and supporting women who need to thrive and curate these healthier futures. I encourage you to support our pillars of programming, please, education, empowerment, and wellness, so that we can continue to do this vital work and help shift the focus toward prevention rather than cure. We are so honored to take up space in this awareness campaign against the insidious threats of breast cancer. To our sisters who are in the fight right now, you were a survivor at the murmur of diagnosis. And to our undiagnosed community, we fight so hard so that you will never have to. Stay informed, be inspired, and walk boldly in your empowerment. Please stay tuned for details about our final installment in the IMPACTHER series. This will be an in-person event, and it will also be a mixer on June 5th at She Space in Houston, Texas. Time and final details will be announced in the coming weeks. And again, thank you, and I wish you all lifelong health.
Thank you, Christina, for shining a pink spotlight on the work that we do. So at Survivor, we are all about providing education and awareness and empowerment, and we like to sprinkle pink on everything we do. So we host in-person events, programs, lunch and learns, brunch experience. So we really try to make learning about breast health and breast cancer awareness fun and exciting, yet informative. We support women who are undiagnosed and diagnosed, uninsured, insured. We offer wraparound services to those women who are in need of financial support. Again, we're fighting the fight year round, not just during the month of October. If you scan this QR code, that will direct you to our website. And we look forward to welcoming you to one of our events coming up. So mark your calendar. Our third and final series in this IMPACTHER initiative will be in person for National Cancer Survivors Month, Thursday, June 5th. You can put on a cute pink dress. It'll be an evening mixer at She Space. And we are so excited to gather, to have engaging conversation with emphasis on mental health and survivorship. So please save the date, and we look forward to seeing you then. We always like to empower our community with some actionable next steps and provide resources, one of which is a genetic risk for breast cancer and health other health conditions. If you want to learn more, you can consider participating in Genome, which is a no-cost community health research program offered by Memorial Hermann. You take a simple at-home saliva test. You can discover whether you carry inherited risk factors for conditions like hereditary breast and ovarian cancer, BRCA1 or 2 gene mutations. So you simply contact that number on the screen. And we also have other resources to share, and those links are available for you in the chat as it relates to community services, patient educational materials, and the Learning Center at MD Anderson Cancer Center. Now, before you log off, please take a moment to complete the post-event survey. We want to hear from you. And if you are a Texas registrant, you will receive a $20 Postmates promo code upon completion of the survey, and we will forward that to you. If you are eligible for continuing health worker credit, be sure to fill out the sign-in and evaluation form, and that credit will be distributed to you within 5 business days. And lastly, connect with us at imasurvivor.org, follow I'm a Survivor, and also connect with the TSU Breast Cancer Center on its social media platforms to stay informed about all of our future events and resources. What an incredible hour and 7 minutes of learning, inspiration, and empowerment on behalf of Survivor and our partners at the TSU Breast Cancer Center. We want to thank you for joining us for the importance of genetics in breast cancer. We thank our keynote speaker, Dr. Portia Johnson-Williams. We thank our expert panelists, Dr. Banu Arun and Ashley Dedman, soon to be Dr. Ashley Dedman, for their knowledge, experience, unwavering commitment to health equity. We are really proud to be part of the Texas Health Equity Initiative, an alliance rather, for breast cancer, working together to bridge gaps in care and improve outcomes for women who are too often overlooked. Thank you for joining us in this fight. Thank you for logging on today, and we look forward to staying engaged with you for future conversations. Have a wonderful rest of your day. Bye-bye.